సార్ లైవ్ అవుతుంది స్టార్ట్.
Good afternoon, everyone. First of all, I welcome you all to join this short session on Know the Basic Facts of ECMO. Before we start, let me introduce myself. I am Dr. Chandra Sekhar, the lead consultant critical care at KIMS-Saveera Hospital, Anantapur. So today I'm in front of you to speak some basic facts of ECMO. As you all know, ECMO has been a revolutionary device for life support, especially in the past few years. The history dates back to several years. So if you look at actual history of ECMO, it's been almost 80 years since it's been used. But over the past few years, especially after the H1N1 and the COVID pandemics, this has really been a revolutionary life support device. So what is this ECMO and why is it so important for survival, especially at the end stages of life? So ECMO basically stands for extracorporeal membrane oxygenator. So what this device does is an extracorporeal, means something outside the body. Extracorporeal, its literal meaning is outside the body, and membrane oxygenation. So it does oxygenate the blood outside the body. So to understand, this is a device basically which helps in supporting the body temporarily, and it helps in bridging of patients, and it also helps us to treat patients in severe conditions for time being, where it provides some support. So as I said, its history dates back to way back in 1950. However, the significant event, the first patient that had successful recovery out of ECMO was in 1971, where a trauma patient, a 24-year-old male trauma patient, has been kept on ECMO because of severe lung contusions, and he recovered ultimately after 3 days of ECMO. So that is considered the first successful recovery from ECMO. Later, next year, followed by neonatal ECMO, where an abandoned child with meconium aspiration syndrome was taken up, and she was kept on ECMO, and she had a good recovery. As you can see in the pictures, we have the baby, and the baby after taken when she was 21 years old. So this has revolutionized the use of ECMO. However, since 1971, almost 50 years after that, the COVID pandemic really brought ECMO into use, widespread use, and the 2009 H1N1 and the 2020 COVID pandemics have really, kept ECMO at regular use. So what does this do? So this actually takes the deoxygenated blood from our body and oxygenates it in an outside membrane, and again through an inflow cannula it sends the blood. So it basically circulates the complete system of blood into the oxygenator, gets the blood oxygenated, and again sends it back to the circuit. So what are the indications of ECMO? So where is it used? ECMO basically provides support, as I have told. It gives us some time before we actually the body gives the time for the body to recover. So what are the indications for ECMO? The indications can be both failures of the heart as well as the lung. So with regards to the lung, there can be severe infections leading to ARDS, or there can be sometimes severe lung injuries which can lead to ARDS, or any other form of pneumonitis, or even respiratory failures. So all types of respiratory failures which are not involving the heart are one indication for the VV ECMO, and the veno-arterial ECMOs, where the mainly patients of the cardiogenic shock, the patients of even the cardiac failure, the acute cardiac failures are kept. So this is the basic ECMO mission. So to just see the several parts of the ECMO mission. So we have the oxygenator, we have the pump, we have the inflow outflow circuits, as well as then we have the heat exchanger. So these are the, as well as the blender and the oxygen source. So these are the important parts of ECMO. So these are the cannulas that we use to take the blood flow in and out of the patient, where we completely connect the circuits to the ECMO machine, and then we drive the blood. So this is the basic circuit and how it flows. So when we see, there are two types of ECMOs that are available. Two types of configurations are. So one is the veno-venous, and the second one is the veno-arterial ECMO. So when it comes to veno-venous ECMO, we place two cannulas, and both the cannulas will be in the venous system. Whereas in the veno-arterial ECMO, one of the cannulas will be in the venous system and the other will be in the arterial system. So the blood is drawn from the venous system and sent back to the arterial cannulas. As you can see, the arrows being pointed out. In the veno-venous, first, if we take the veno-venous, the more simpler of the two. So in the veno-venous, the blood is drawn continuously from the venous femoral vein here in the picture. So it is drawn from the veno-venous, then it goes to the pump, where and the pump then flows it to the oxygenator. So oxygenator is where the deoxygenated blood gets converted to the oxygenated blood, and it is flown back into the venous, the superior vena cava over here. So internal jugular vein, through the internal jugular vein, it goes through the superior vena. So this is a simple veno-venous ECMO, and the other one is the veno-arterial ECMO. So when we take the veno-arterial ECMO, here we are drawing the blood through the femoral vein again in the circuit as shown in the circuit, and it goes through the pump to the oxygenator, and finally it comes back to the femoral artery. So if you take a look back at the components, so here we see the heater and the cooler, as well as the pump. So this is how it simply looks, where it is passed to the pump, then followed by there is a heat exchanger where it maintains the patient's body temperature along with the pump, then the oxygenator and the return line. So there are two important things over here. One is the blender as well as the oxygen source. So that is where the oxygen is being supplied with a flow percentage with FiO2s that can be supplied from 21% to 100%. And it also removes with the flow gas, it also removes the carbon dioxide out of the circuit. So this does the function of both introducing the oxygen as well as removing the carbon dioxide. All components over here have an important role to play. So when we connect this circuit, there is a lot of monitoring that goes on V1. We keep, apart from the regular monitors of heart rate, blood pressure, saturations, temperature, we also keep monitoring the how the blood is flowing through the circuit. There are the pressures that we continuously monitor, the pre-pump as well as the post-pump pressures. So if there is any change, a drastic change in the pressures, that indicates there might be a clot in the circuit. Along with that, we keep continuously, because since it's an external circuit, it requires continuous flow of heparin and monitoring of the activated clotting time. So both this activated clotting time and the heparin needs to be given. So along with that, there will be monitoring of other aspects as well. We look for the signs of bleeding. We look for the signs of other physical assessment signs, like how the patient GCS is, how the patient's on a day-to-day basis, how the patient's chest X-rays are, and the bedside ultrasounds. So this is actually a complete system which requires thorough monitoring, and there are separate charts where we maintain the entire monitoring of the patient over 24 hours. There is a complete list of protocol that has been formed, and it is followed as per the international guidelines. So the most common one that we have been using is the veno-venous ECMO, because most of the patients that we come across are usually viral pneumonias with landing up in severe ARDS. Especially after COVID, there have been several viruses which mimic the COVID virus, and there have been several initial presentations of patients with 3 days of breathlessness, 5 days of breathlessness, coming in severe breathlessness with respiratory rates of around 35 to 40. So that is when we take them up. We get an initial CT chest done. So the CT chest followed by the arterial blood gases. So if the arterial blood gas PF ratios are less than 150, usually we tend to counsel them for veno-venous ECMO, provided their heart condition is good. If the heart condition is also bad, suppose saying there is a added viral myocarditis, or if the patient has any pre-existing comorbidities of the heart, then probably we would suggest a veno-arterial ECMO. So the introduction of this requires the complete team to be available. Along with that, we need to have a team of 3 or 4 doctors for cannulating the system, then monitoring, as I've told, monitoring the entire process through. So coming to like where we really use it. So I have already told where we really use it. So with regards to complications, so before I jump into the complications, there have been a lot of people asking about the cost effectiveness of ECMO. Yes, there have been several studies with regards to the cost effectiveness of ECMO. If you consider that ECMO gives a particular rest to the lung and it helps the lung recover earlier, so ECMO definitely is cost effective in terms of reducing the ventilatory stay. It reduces the chances of infections in terms of prolonged ventilatory stay. So if you work out the overall cost, probably it might be effective in terms of providing the support for the patient till his lungs actually recover. So his lungs can be rested with an ECMO support and can be recovered. So as you know, no patient, no procedure is free of complications. Yes, ECMO has its complications, and most of the complications are associated with either bleeding or some kind of thrombosis or some kind of infections. So infections can be starting with the procedure to the invasive cannulas, or through the circuit, or through the general infection that might have worsened. And bleeding, especially because we are running heparin through the circuit. Though we monitor the ACT and other coagulation parameters regularly, there can be chances of bleeding. Bleeding from all the sites, including the intracerebral hemorrhages, the pulmonary hemorrhages, the abdominal hemorrhages. And there can be vascular injury during the introduction of the cannula, or there can be vascular injuries post introduction when the cannula can get displaced or other things. And when the blood bleeds into the pericardium, there can be risk of pericardial tamponade and high chances of ischemia, because we may alter the clotting mechanism when we are introducing it. So overall, looking at the complications, one need not fear, because it's a definitely much bigger perspective when we see the life of a patient. The complications, as far as internationally known, are seen in around 20% of the patients, all the above complications, with the majority being the bleeding. So, in short, if I have to summarize, so this has been a revolutionary device, which of course has been costly, but as I have spoken, the cost effectiveness is much better compared to the cost incurred during the introduction and the usage of ECMO. And one more advantage is ECMO definitely supports patients who require bridging towards cardiac transplantation or a lung transplantation. Along with that, it also helps in bridging patients, especially short illnesses when you are expecting an acute illness. So, considering these facts in mind, I think this is definitely a go-to, especially in cases of young female patients or young male patients who suffer with respiratory illnesses or who are into cardiac failure or into lung failure requiring transplantation. So, to end, no procedure is easy, but I think this is definitely the must use mission. So I request all of you to know more about this, especially this basically has been awareness for the general public. So I request all of you, if any doctors are following this, I request all of you to go more through this and enlighten the patients regarding this. Thank you.